So thank you to the organizers of this session for the opportunity to present this research that I've been doing in collaboration with the Mesoamerican Coalition for the Reproductive Rights of Women with HIV, and as well as with my co-authors Claire Albert and Gabriela Garcia. I'm going to speak to the issue of coercive and forced sterilization among women with HIV. So to give you a little bit of the context that I'm talking about, in these 4 Latin American countries, there are an estimated 60,000 women living with HIV. These are all concentrated epidemics, so less than 1% general population prevalence, but above 5% in certain most at risk or vulnerable populations. And those are universally men who have sex with men in the region, male sex workers, where research has been done, trans women, and then depending on the country, female sex workers and injection drug users. And as you can see here, in terms of the proportion of the population of people that living with HIV that are women, that varies from 22% in Mexico to 41% in Honduras. And for the region as a whole, the 1.5 million people, it's about 1/3 women living with HIV. So when we think about HIV-related discrimination and coercive and forced sterilization based on international human rights law and the commitments that countries have made both to non-discrimination and the right to health, which includes the right to sexual and reproductive health, women living with HIV and other women should not be experiencing these rights abuses. However, women living with HIV from around the world, from Asia, from Africa, from Latin America, continue to report reproductive rights violations that range from the denial of information and services to, at the extreme end of the spectrum, forced abortion and forced sterilization. So what I'm talking about specifically, coerced sterilization occurs when misinformation, intimidation tactics, or financial incentives or access to health services are used to coercively sterilize women. And forced sterilization is when sterilization occurs without knowledge or without informed consent. So this is a serious human rights violation. It's a violation of the right to health, and it's also a form of violence against women. This research was a very participatory process. The survey instrument was developed with feminist lawyers in collaboration with women leaders living with HIV from the countries that participated in the research. And then peer researchers went out into the community and actually applied the research to other women living with HIV. And we involved the 3 regional networks that have large membership of women living with HIV, the International Community of Women Living with HIV Latin America, ICW Latina, Red Trust Sex, and Red Lac Trans, as well as 25 other organizations. Now, the sample does have limitations in terms of the fact that it was a convenient sample where women were recruited through the social and professional networks of the peer researchers, but it also has strengths because of its geographic scope of the 4 countries, and that 37 different political districts were included. So we're not talking about the experiences of women in one single clinic or even in one city or one country. And I'm presenting here both. So the question about pressure to sterilize was whether women had experienced pressure to sterilize since their diagnosis. And if they answered yes, then there was an open-ended question, could they please describe that? And so I've done both a quantitative and a qualitative analysis. Who were these women? So you can see on this slide that most were of reproductive age. Slightly more than half of the women had primary education or less. Almost all had children. 27% had had a pregnancy since the HIV diagnosis, and that could either be that they were diagnosed during pregnancy or that they had a pregnancy subsequent to the diagnosis. It's a joint variable. A little less than half were in a stable union, and we had good representation both of Indigenous women and women of African descent in this sample, and most of the women, almost 90%, were taking antiretroviral therapy, and all were in contact with health services. About half of the women were poor, as measured by not having a cement or tile floor in their home, and 18% could be considered very poor in this context, in that they cooked with firewood. They didn't have gas or electricity in their home for cooking. And another 18% were relatively better off in that they had home internet. So that's quite a luxury in this context, and expensive. So across the countries, almost a quarter of the women reported having been coerced to sterilize, and that ranged from 17% in Nicaragua to 28% in Mexico. What women said about the pressure and coercion to sterilize makes it very clear that this is coercive. So women were misinformed about prevention of vertical HIV transmission as a way to convince them to be sterilized. And I presented another session earlier today. In this sample of women, only half of the women, even though they're in treatment services, have been told about prevention of vertical HIV transmission and how effective it is. So women are not being informed about the basics of HIV treatment and what we know about it. Women were also threatened with poor outcomes that do not need to be true with proper medical management about their and their children's health. So both that their children would be infected if they had another pregnancy, and that they themselves could die. As in this quote from a young woman from Honduras who clearly wanted another child and was told that she had to be sterilized because if she had another pregnancy, it would lead to her death. And women were denied their reproductive choice and choice to choose their contraceptive method because they were living with HIV. In this case of being told that they couldn't refuse because she was living with HIV. Also, in the delivery of healthcare services, were made a condition of accepting sterilization. So women's greatest risk, here this is common, and this is not only the experience of women in Latin America, but when women are going in for cesarean section is a common time for them to be pressured to accept sterilization. So they're seeking and afraid about transmission of HIV to their child, and the nurses are making her sign papers for sterilization as a condition of having that cesarean section done. Or, as in this case, threatening to withhold formula, which is also part of the prevention of mother-to-child transmission if she doesn't accept sterilization. In all 4 countries, we also identified cases of forced sterilization, so sterilizations that were carried out without women's informed consent. This could either be when women had signed, thinking that they were consenting either to cesarean section or to another kind of abdominal surgery, but not consenting to sterilization, to their knowledge. And this has also been identified most famously in the Namibian cases of forced sterilization. Or in this very egregious case from Mexico, when the woman was asleep because of anesthesia, they actually took her thumb and made her mark on the paper instead of her signature for forced sterilization. In the multivariate analysis of women's social and economic and fertility history characteristics, what is very clear is that women's greatest risk factor was coming into contact with maternal health services with a known HIV diagnosis. And so women with HIV who had a pregnancy with a known diagnosis were 8 times more likely to report being pressured to be sterilized than women with HIV in the sample who had not had a pregnancy with a known diagnosis. Women with 2 or more children, I've lost my little mouse, were also nearly 3 times as likely to report being pressured to sterilize. And women with higher education were also more likely to be pressured to sterilize, whereas being over 45 and of African descent was protective in this sample. So we can say, based on this analysis, that coercive and forced sterilization was a frequent reproductive rights violation, with nearly a quarter of the women reporting this across this country. So we see a systematic violation of women's rights and human rights in the pressure to sterilize. And we can see that based on women's reports of how they were coerced, that this is clearly motivated by HIV-related discrimination, which has been an issue that was raised in Namibia when the judge said that he admitted and he agreed that women had been forcibly sterilized without their consent, but questioned whether or not there was sufficient evidence that this had been motivated by HIV and thus was a form of discrimination. And we think that this evidence clearly shows that it's HIV-related discrimination that is driving the pressure to sterilize. And it's very concerning that contact with maternal health services with a known HIV diagnosis was women's greatest risk factor, because given the possible poor health outcomes if women living with HIV are not in care and are not accessing essential HIV treatment services during pregnancy, we know that women who are not on treatment in the sub-Saharan African context have 8 times the rate of maternal mortality compared to HIV-negative women. So we need to make sure that maternal health services are friendly, welcoming, and respectful places for women living with HIV. So, to conclude and recommend, there's a need for comprehensive sexual and reproductive health information that includes information on preventing vertical HIV transmission, how to become pregnant safely and have a safe pregnancy, as well as living well and for a long time with HIV as a standard part of HIV care. And this information should be absolutely required as counseling for any instance of informed consent for sterilization among women living with HIV. It's basic information. There's also a need to educate providers about HIV and about reproductive rights. So this is the perspectives of women living with HIV. There's a need to do more research with providers to identify the attitudes and knowledge gaps that are driving these behaviors. And given that we see that it's in gynecology and obstetric services, so maternal health services, where women are mostly having these experiences, we would prioritize those services for education and training on this issue. And plus, training maternal health providers about reproductive rights will serve all women. We need to actively involve women living with HIV, networks of women living with HIV, in the monitoring of these services in order to both prevent and sanction this reproductive rights abuse. And the states have made commitments on the right to health and the right to non-discrimination that they need to honor by making mechanisms to investigate and sanction these kinds of abuses available. And so the African Commission on Human and People's Rights has made a statement in 2013 on the state's responsibilities and needs. That the recommendations are very close to these, and this shows that this is not only an issue for Africa, but also other regions of the world, including Latin America. I'd like to thank and acknowledge all of the organizations and women who participated in this process and are members of the Mesoamerican Coalition for the Reproductive Rights of Women with HIV, as well as the donors and the institutions that have supported this research, in particular the Ford Foundation, Office for Mexico and Central America, that has been supporting all of this process of research and capacity building since 2008. Thank you very much.